All right, well, welcome everyone. We have a lot of information that we want to run through over the next hour so we can get started here as more people continue to join us. We do appreciate you joining us for this today. My name is Brian Harris. I'm one of the consulting directors at BlackTree Healthcare Consulting. I'm joined by one of our consulting managers, Sam Soulas, and Beth Morren from Elara Caring. Today, we're really going to take a deep dive into Medicare Advantage. And really why that's relevant, provide some recommendations as to how to be successful as we see that Medicare Advantage landscape continue to grow. I know we just gave a little bit of an introduction there, but again, Sam and I are from BlackTree, and we're lucky to be joined by Beth, who is the Vice President of Managed Care for Elara Caring. Beth joined Elara in 2019 and is responsible for their entire managed care program, which covers 16 states and 4 different service lines. Prior to joining Elara, Beth was at Blue Cross Blue Shield of Texas and had a long tenure there, working with contract negotiations, strategic planning, network builds, pay-for-performance programs, as well as national account management. And throughout her career, she's held various leadership positions and led numerous committees, including one to build out the ancillary networks, overseeing a variety of specialty ancillary providers. So again, we're very lucky to have Beth join us and share her expertise there. Before we dive into the actual material, just want to have a few housekeeping items. You will see on the right-hand side of your screen, we have a few options. The chat box can be used at any point in time to ask any questions, provide any feedback. We will be doing a Q&A at the end, so you can use that or the Q&A section to ask any questions you may have. There is also a polls section over there on the right, with a couple of questions that we're looking for feedback from you all. I would love to get feedback on the questions in there and help that to build out some of the items that we're going to be talking about, and you can answer those at any point in time. In terms of the materials, the handout section on the right will allow you to download the PowerPoint slide that we're going to be going through at any point in time. Following the webinar, we will also make available a replay video as well as a one-page summary of everything that we discussed. So with that, what we're going to look at today is here on this agenda. So we're going to start by looking at the growth and relevance of Medicare Advantage, really set the stage of why is this such an important topic and why do we need to be paying attention to it. From there, after we look at some of the expansion and current growth, we're going to look at operational challenges and take a look at how Medicare Advantage is different from traditional Medicare. What are some of the operational and revenue cycle items that you're going to come across when dealing with the Medicare Advantage plans? After that, we're going to take a look at strategies for managing your contracts and how you can be successful in building relationships with these payers, negotiating contracts, and identifying when it may be time to renegotiate those contracts, including tactics as to how to put your best foot forward and really get as successful of a position as you can with these Medicare Advantage plans. Then we're going to wrap some things up with key takeaways and questions from you all. And again, want to dive into this, a lot of information. I want to make sure we leave time for those last pieces. I'm excited to hear feedback from everyone. So starting with the growth and relevance, want to go through some quick facts on Medicare Advantage here. Several of you may have seen similar stats in dealing with Medicare Advantage or looking into this, but in the current year, around 36% of all Medicare beneficiaries are enrolled in a Medicare Advantage plan. So a little over a third of those beneficiaries. You'll see the chart that we have over there shows that really over the last 15 years, we've continued to see growth in this percentage of Medicare Advantage beneficiaries in accordance with the whole Medicare population, to a point where we're now over 24 million enrollees in Medicare Advantage, which is a 9.5% increase over the past year, as opposed to even some 7 and 8% increases that we saw before that. So summary there, we're seeing Medicare Advantage enrollments grow, and we're starting to see it grow at a faster rate than we have in the past, likely due to some additional marketing of the Medicare Advantage and also some of the expanded benefits we're going to talk about in a second. We do anticipate this to continue, and in fact, the CBO actually projects that over half of Medicare beneficiaries will be in a Medicare Advantage plan by the year 2030. One of the important parts to remember as we go through all of our discussions today is that we're going to be talking about things at a global level, but you really need to understand your market. We have on the screen here a map of the highest utilization of Medicare Advantage plans across the states. Any state that you see in red is above 40% of the Medicare beneficiaries in MA, with going down to the orange and gray is the lowest. You'll see Oregon, Minnesota, Wisconsin, PA, where BlackTree is based, Florida and Hawaii as the highest states. Puerto Rico, not technically a state, but they're also up around 70% of Medicare Advantage enrollees. We do see typically in the middle of the country, you'll see on those orange states there that they have a lower market share in terms of Medicare Advantage as opposed to the traditional Medicare. So again, just wanted to provide some stats there as well as take a look at the specific payers. You'll see here UHC, Humana, and Blue Cross Blue Shield, if you look nationally, are the biggest players in the Medicare Advantage space, making up close to 60% of all Medicare Advantage enrollees. But again, important to remember, understand your market. We work in some states where Blue Cross Blue Shield is much higher than UHC, other states where Humana is dominating the market share really. So you really want to take a look at that, understand your market, understand the plans with which you participate, and make sure that you're reacting according to that. That's going to be a big focus with Medicare Advantage in general and really tie into what we're going to be talking about throughout this webinar. So we are seeing growth. We do want to talk a little bit about the expansion as well. So we list some items there. On the skilled home health side, looking at the adoption of PDGM. That obviously came into play for traditional Medicare on January 1st of this year, and we've seen Medicare Advantage beneficiaries react to that as well, which we can jump into. Non-skilled home care, that started in 2019. We'll go into some more details there, but really looking into that non-skilled home care benefit, some of those different supplemental benefits that can be made available to the patients that are out there. Hospice, that's the big one that's on the books looking into 2021 as of right now. We'll go into that and the value-based insurance design program and what Medicare is looking to do with that, as well as telehealth. That's been very prevalent in traditional Medicare right now as we look through the current PHE, the use of telehealth and the ability of providers to leverage telehealth expanding. The one thing that's really important to call out here as well is that typically these Medicare Advantage plans are making benefit package decisions 1 to 2 years in advance. Typically, we see these decisions being made in June, looking forward to the following year. So we say that to say, if we look at hospice, for example, Medicare is looking to create that Hospice Carve-in in 2021, but that's not going to result in every single Medicare Advantage plan automatically adopting hospice and making it a benefit. We'll go into some of the adoption of the non-skilled in a second, but what we're seeing is typically delayed or slow adoption for a lot of these new benefits. These plans are looking to understand that. They're looking to see how the market reacts, how their competitors react. So they may wait a year or two to build these into their benefit packages. And also, they may be at a point where they've already decided what they're doing for 2021, and it's too late to build out something for hospice or build out something expanded on the non-skilled home care side. CMS has said that they're giving a little bit of additional flexibility due to everything going on with the PHE, but we do still expect to see these things maybe a bit delayed and take a year or two to really see widespread adoption as Medicare makes these additional benefits available to Medicare Advantage. Looking at the skilled home health side, again, the biggest thing there, Medicare Advantage has been in that industry for a while in that service line, but PDGM on 1/1/2020. You might have heard us talk about going into 2020 that the biggest uncertainty really was Medicare Advantage, what Medicare Advantage was going to do, how they were going to reimburse, and which of these new Medicare guidelines were they going to adopt. And what we have seen, kind of what was expected, is that there's been varying adoption across the plans across the country, with some plans adopting PDGM in full on day one, and other plans that we're still trying to figure out exactly what sort of mix of per visit versus PDGM they have adopted. That's actually one of our poll questions that we're looking for feedback from you all as well, is what are you seeing in terms of the reimbursement there? Because we have seen variance and we have seen plans that have communicated better as to what they're doing. That kind of ties in line with some of the clients that we do billing and collections for, in that we saw a big spike in AR from December to February, with that AR for Medicare Advantage plans really rising between 20 and 25% across the providers that we work with, and then steadily coming down since February as some of the MA plans figured things out, and we really were able to see how the MA plans had reacted. It's kind of what we expected as well, in that it lagged a little bit behind traditional Medicare there, but we still aren't seeing providers out of the woods yet and fully understanding how these Medicare Advantage plans are operating under PDGM, and really what they're going to do going into 2021 as we see the RAP impact diminishing, going away, and putting that notice of admission in place. That's kind of the next question, is are Medicare Advantage plans going to adopt these as well? And that's something that skilled home health providers really need to pay attention to as we continue further into the PDGM world. Looking at the non-skilled side of home care, Medicare has made several new benefits available over the past couple of years, starting in 2019 with what they're calling the primarily health-related supplemental benefits. That includes adult daycare, respite care, safety home modifications, and a whole other list of non-skilled benefits that Medicare Advantage plans were now able to add to their benefits package. In 2020, this was expanded even further to the Special Supplemental Benefits for the Chronically Ill, or SSBCI population. So again, just additional non-skilled benefits. Chronically ill, by definition, is that the patient has one or more comorbid and medically complex chronic conditions that is life-threatening or significantly limits their overall health. They have a high risk of hospitalization, and they require intensive care coordination. So we list some of those out as well. Again, in-home support services, helping the patients out with some ADLs, meal prep, food and produce services to make sure they stick to any nutritional plans, and different complementary therapies. In terms of the adoption we talked about at the top, we have seen 361 plans now adopting the primarily health-related benefits that were made available in 2019. That tripled compared to the 102 that offered it, and around 245 plans adopted those SSBCI benefits. So a lot of plans there. I mean, there is some overlap, but we're close to 600 plans offering these benefits in some form. But when you look at the overall Medicare Advantage payer side, there's around 3,000 to 3,500 plans out there. So the fact that only 600 are offering these benefits a year and a half in shows that there is some delays in adopting these. That being said, we do anticipate seeing these continue to grow and expand and see more Medicare Advantage plans take these on. Did want to call out of those SSBCI benefits, the pest control and food and produce, again, tied around those nutritional plans, have the highest volume of these Medicare Advantage payers that are including that in the benefit package and reimbursing those at this point in time. Again, we have seen a bit of a delayed adoption as these plans look to figure these out and really add them to the benefit package. But we expect to see that continue to grow as they figure out really how to deliver those services to their customers and also how to build out into the whole care continuum. The other big one that we mentioned earlier is the Hospice Carve-in. Up to this point, any Medicare beneficiary, even if they had Medicare Advantage plans, have reverted back to traditional Medicare when receiving the hospice benefit. The value-based insurance design, or VBID demonstration, was created by CMS to really carve hospice into that Medicare Advantage benefit. As of right now, the goal is to start that demonstration on January 1st of 2021 and have the demonstration go through 2024. That being said, with everything going on with the PHE, there has been advocacy about delaying this, as well as, or in the same vein that some other things were delayed, such as the OASIS-E, with NOC recently sending a response proposing a delay until January 2023 to allow hospice providers to really focus on caring for patients under the current public health emergency. As of yet, the plan is still 1/1 of 2021, however. CMS has not yet released the participating plans. So again, looking at adoption and probably some delays, it will be interesting to see the volume of plans that are actually performing this Hospice Carve-in starting in 2021. But CMS has come out and said that they must offer benefits to both in-network and out-of-network providers for 2021 and 2022 in order to kind of phase this in. The hospice benefit is definitely the biggest part of VBID, but did also want to call out that there's other pieces in there around wellness and healthcare planning, advanced care planning, and different parts C and D inventives specifically around the drugs in the hospice benefit. A few other items that CMS released, the Medicare Advantage plans will also be required to provide palliative care and transitional concurrent care services if they choose to participate in the VBID. Again, looking at the whole care continuum. And some of the billing instructions, Sam's going to talk about this a little bit in the operational challenges, but leads to some of the uncertainty going into this. From an MLN article that was released with the number being there, they have indicated that claims will still need to be submitted to the MACs, but no real clarity on whether you'll also have to submit a claim directly to the Medicare Advantage plan, which we've typically seen on the home health side. You'll still be able to bill the the payers out of network, and those rates must be at the traditional Medicare rates at a minimum. The biggest piece there is on NOEs. CMS has indicated that the 5-day timely filing window will still remain, but has not given any guidance on to whether you'll submit those to max, whether something will have to go to the Medicare Advantage plan. So still a lot of uncertainty on the billing front here, even though some guidance has been released, which ties into the overall uncertainty as hospice is about to be carved into this in 2021. Finally, authorization. Sam will talk about that a little bit as well, but MA plans will not be able to require any authorization or utilization management processes that will impede timely access to care. So we're reading that as to say that you won't need to get authorization for these hospice services for the MA plans going into 2021. Typically, we see that as a barrier on the home health side right now. So if that carries out as expected, that would definitely be a positive as we look to adapt this for the Medicare Advantage plans. But that being said, the plans will be able to perform some prepayment reviews specifically to ensure that the drugs are covered under the hospice benefit, and looking at those long lengths of stay, typically those that are over 180 days, which is that 6-month terminal illness period in the hospice definition. So really something to take a look at as MA plans look towards this hospice benefit. Sam will go into that in a little bit more detail, but wanted to call that out of the information that we have as of right now. And then finally, looking at telehealth, again, that's been a huge item in traditional Medicare, especially during the PHE, as there's been difficulty in actually going to patients' homes and providing the services, especially on the hospice side, where a lot of services provided in nursing homes. In the past, MA plans have been granted more flexibility, but as we've talked about up to this point, we haven't really seen widespread adoption of that as of yet. Something to really pay attention to, both as the Medicare Advantage benefit packages continue to expand, and hopefully we see some continued expansion in traditional Medicare. As of right now, it's allowed on the care plan and cost reports, but still doesn't count towards reimbursement or the LUPA thresholds. So if CMS were to change course, I know congressional action is probably needed there, but if that were to be expanded on the Medicare side traditionally, we may see that on the Medicare Advantage side as well. So something to really pay attention to as we look at the expanding Medicare Advantage benefits in general. So with that, again, really wanted to set the stage in terms of where Medicare Advantage is at right now, some of the expansion that's coming, but I'll turn it over to Sam to talk about some of the operational challenges you need to be aware of as you look at these Medicare Advantage plans and being successful with them.
Thank you, Brian. As Brian mentioned, we thought it was very important today to talk about some of these unique operational challenges to Medicare Advantage, again, in comparison to what we see with traditional Medicare. It's important to understand these challenges so that we can come up with some solutions to proactively manage these plans. A lot of what we're going to talk about is what we've seen with, of course, the Medicare Advantage benefit for skilled home health and the challenges that are presented to us with managing those MA plans. In terms of the revenue cycle, these are really the 5 functional areas that we see differ the most between a Medicare Advantage plan and traditional Medicare. Authorization being first and foremost. Authorization is a top write-off for our clients. Providers are constantly trying to navigate requesting authorization within the tight time frames that payers are putting on us, making sure that they're obtaining authorization at the right re-auth time points, figuring out payer by payer what are the different documents that are required for an approved authorization. It's a real challenge for a lot of our providers to obtain that authorization. A second common pain point we see is document management. A lot of our MA contracts have that language per CMS guidelines. So a lot of providers are choosing to hold their claims for those physician signatures and for completed face-to-face encounters like we do with traditional Medicare. The challenge there is that most of our Medicare Advantage contracts have shorter timely filing windows for us. So we're having to obtain the same amount of information in a shorter window of time in order to avoid some of those timely filing denials. On the billing side, Brian hit it home. There's just a lot of uncertainty. As we saw with the movement from PPS to PDGM, we helped a series of our clients with contacting Medicare Advantage plans and finding out if they were going to adopt the PDGM reimbursement methodology and the different claim requirements. And we received a whole slew of different responses. Some payers had these really nice black and white publications right on their website with their different requirements going into PDGM, and some account representatives or provider representatives that we reached out to didn't even know what PDGM was and couldn't really provide us any specific guidance as to what to bill, how to bill. So that's a challenge that a lot of providers face, with dealing with all these multitude of different payers, and the payers just starting to understand these benefits as well and what they should expect on their claims and process in their systems. Because of a lot of that uncertainty, we also see a lot of challenges on the collection side. Again, each payer kind of has their own unique, different way that you should follow up and process those claims. Some payers, it's best to work in their provider portal. Some payers, their portal isn't clear enough, so we have to always be picking up the phone to contact a payer representative to get the status of our account and to potentially reprocess the claim, all the while potentially dealing with long hold times when contacting those payers. And a lot of times these systems just aren't set up correctly. So we see a lot of payer processing errors. We may have our billing requirements right finally that they've given us guidance on, but their systems just aren't processing them correctly. They don't have it set up. I feel like some of these MA plans just got a handle on PPS and got their system set up straight for PPS, and now we're switching over to PDGM. So that'll be interesting, and that'll be a challenge, and we'll also see that challenge as MA plans start to adopt new benefits such as hospice and telehealth and such. And then on the reporting side, there's just different benchmarks we have to set, different metrics we have to measure for these Medicare Advantage plans compared to our traditional Medicare. Some solutions that we recommend, we're really focusing on the best protocols that you can negotiate with your payers. And once you have those protocols set in place, how are you getting to know your payers so that you can uniquely manage to each of their individual nuances? You're going to see that that's really a theme, is getting to know your payers, understanding what the authorization, billing requirements are, their cash flow windows, so that you can proactively manage to each of those different payers that you have within your mix. So starting with authorization, first and foremost, we really recommend that you structure your team and your staff assignments by payer so that each of your individual staff members is able to become an expert in those payers. And even more importantly, they are able to build those relationships with those authorization representatives. A lot of times the same representative is going to be reviewing those authorization requests. So they'll call you up and say, hey, Sam, we're missing this piece of paperwork for John Smith, can you please send that over? And as you start to gain that payer intelligence, make sure that you're documenting those different payer nuances. Beth Ann a little bit later is going to talk about consolidating payer information into a payer matrix, and that's a really great place to document some of these payer nuances so that, one, you can have cross coverage between your staff members, and two, you can provide some education to your branch locations, whereas one branch in one part of the state might have a larger presence with a certain regional plan, and they may have some unique authorization requirements. It's best to kind of get ahead, let those clinicians and those branch managers know some of those unique requirements so that they can manage to that. Third, we really recommend optimizing your EMR to individualize settings. What we mean by that is don't just have one authorization setting set up for all of your different payers. There's going to be different reauthorization time frames. There's going to be different response times from payers in terms of when you hear back on the status of an authorization. So tweak those settings so that you're managing to each of those plans according to their specific trends. And then, to the best of your ability, Beth Ann's going to speak a lot about working with payers, negotiating those contracts. Talk about the authorization protocols. Can you get that initial visit in your contract that it doesn't require authorization, so you're not scrambling in the beginning? You can focus on that timely initiation of care. Is there a way that they can access some of your clinical records and you can get an auto approval for a certain number of visits? Just start to have those questions with your payers and plans when looking at those contracts. On the document management side, as we discussed, the real pain point here is being up against those shorter timely filing windows that MA plans place on us in our contracts. Again, documentation, make sure that you understand and you know the timely filing limit by payer. That's always going to be written clearly in your contract. So just go through all your contracts, document that information so that you can know and then put that information to work. And what I mean by that is when you're strategizing your accounts receivable, your unbilled accounts receivable, your outstanding orders, your face-to-face encounters that you still need to track down, prioritize those certain accounts based on that payer and their individual timely filing limits. If you have 100 orders and 50 are Humana with 90 days and 50 are Blue Cross with 180 days, well, prioritize, strategize your team so that they're going after those Humana orders first so that we're not up against these timely filing limits and potentially having denials for that reason. And then again, always ask when you're negotiating these contracts, ask about that timely filing limit. Beth Ann provided Brian and I feedback that a lot of times these payers might have a range. So they may put 120 days in your contract, but they're really allowed to go up to 180 days. They may not be able to go past that, but it's always ask. It's always worth it to ask and see if they can push it a little bit more. Those 30, 60 days sometimes make all the difference when getting back those signed orders. In terms of billing requirements and really firming those up and understanding the individual requirements by payers, we recommend first making sure that you have an account representative for all of your contracts so that as we see this shifting landscape with reimbursement methodologies, new benefits being adopted, you can contact those account representatives to confirm requirements. Like what we did with PPS versus PDGM is we really made sure that we had in writing that they were confirming they were moving over to PDGM. If it was a per visit claim, that they were going to require PDGM HIPS code. And the purpose of this is their systems may not be set up correctly yet. So if you have a lot of denials for that reason, for some misdirection, you can always go back and appeal those decisions or appeal those denials with some of the guidance that you may have received from your account representative. It's also important as we navigate through this landscape with MA plans to track your denials. Understand your denials that you're receiving in a timely manner. Don't just look back on them as you're potentially making some of your write-offs, whether that's in your clearinghouse, they may have that functionality in there, or through your EMR, maybe structuring your collection notes in such a way that you can analyze those denials and adjust your EMR setup accordingly. Don't just let those same denials be fixed by your collections team over and over and over again, even though you still may get paid, but let's work more efficiently, let's work smarter. We really do have to do that with these plans. And in some scenarios, if your EMR does not have the capability to potentially format a claim in just that one little specific way that MA plan wants, we always have those couple plans that want to have that one additional requirement that makes it difficult for us, or we may have to pencil in on a paper claim or reformat in the clearinghouse. Talk to your clearinghouse about setting up some rules so that they can customize those claim formats for you. A lot of times clearinghouses have the ability to, if you submit a claim through, add a code, remove a code so that it meets those payers' individual billing requirements. We had a client where one of the VA payers, this is when Social Security numbers were still the policy number, the VA didn't want an A or a letter at the end of it. They just wanted the number from the Social Security number, from the Medicare HIC number. So what our clearinghouse was able to do was when it saw that policy number come through for that plan, it always removed the letter at the end. It was a heck of a lot easier for us to do that than trying to educate our intake team time and time again to not include that letter. So that's just one good example of how you can utilize your clearinghouse to help you meet some of these billing requirements. On the collection side, we also see adjudication windows really varying across different payers. And you're going to want to make sure that your billing manager understands those adjudication times, most importantly for cash flow trends, but also so that they can strategize their team accordingly. And if you have one payer, such as a Humana, that may pay in 7 days, we see that a lot, versus a Veterans Affairs that pays in 45 days, we can have our collections team members follow up on Humana a lot quicker rather than the Veterans Affairs, because we know we're going to be waiting those 45 days to get an initial determination anyways. So again, we want to think about efficient management of these plans in the receivable for MA. Another kind of ground level work that we can do is, just as we're on the phones with these payer representatives, provide them education. Another one of my clients just told me recently that with PDGM, some of their Aetna claims are paying correctly, some of them are overpaying, underpaying, and what they've determined is it's based on the processor. So they have to get on the phone, provide some education to those payer representatives on how PDGM works, what are the different payment requirements there, and actually give them one-on-one education so that they can process their claims correctly. We see that a lot. So be giving guidance to your collections team members to really be on the forefront of education while they're on the phone calls with those provider reps. And lastly, we really recommend that if you have a big issue with a payer, to rely on payer projects. Work with that account representative that we talked about, that you can identify through the contract management process, to help you work through a consistent denial that you're receiving in error. If your accounts receivable starts to grow and grow and grow for the same error, talk to that payer and see how they can help you maybe reprocess those claims in bulk rather than your team trying to consistently reprocess a claim individually one at a time. It'll be a lot more efficient that way, and a lot of times account representatives are able to help you there. And lastly, on the financial reporting piece, as I mentioned before, we really just need to look at different benchmarks and metrics for Medicare Advantage and non-Medicare in general versus traditional Medicare. Unfortunately, we really have to expect these MA accounts to age for all of the aforementioned reasons, that they have longer processing times, longer adjudication windows, that their systems may be denying us incorrectly. And so those accounts are going to age, and we want to reserve accordingly. As they start to get into those older buckets, we recommend that you reserve more and more. Typically, BlackTree's best practice benchmark for non-Medicare bad debt is about 1.5% to 2%. Be looking to set that goal for your agency for Medicare Advantage reserves and bad debt. We also want to establish some appropriate days sales outstanding expectations. Medicare, we know their payment floor is just about 14 days. So if you get that claim right, in 14 days, you can expect to receive payment. That is not the case for our Medicare Advantage plans. They're going to be paying us oftentimes a lot longer. We may be facing that initial denial because of all of this uncertainty and having to work the claims to really work for that cash. So we can expect our days sales outstanding to be longer than our traditional Medicare, and a good benchmark there is about 75 days. And understanding your cash flow trends. As I said, that billing manager that's managing your department should really understand the volume that you're billing for each payer, especially your large payers that make up a lot of their mix. What is their cash flow window? So you can understand that if you're having a low cash flow month for Humana, because we should have received a lot of the cash in the door already for that big billing submission that we may have done in the beginning of the month. And lastly, this goes along with kind of timely feedback. Set up specific adjustment codes in your system so that you can accurately report on some of those contributors to your bad debt. Instead of just having an adjustment code that says bad debt, maybe build in some ones that are specific to authorization or a timely filing denial due to unsigned orders, so that you can really diagnose where some of your obstacles are. And more importantly, too, perform those adjustments monthly. One, to keep your accounts receivable accurate for your collections team, but two, so that you can look at those adjustments monthly with some of your other revenue cycle departments, diagnose the issues, and work to proactively manage those. So we're definitely up against a lot with MA plans. There's some additional challenges with MA that we see, especially in comparison to traditional Medicare. So Beth Ann's going to speak here about some strategies for managing your contracts, negotiating your contracts, so you guys can be set up with a successful contract from the beginning.
Well, thank you, Sam. So I'm excited to be here today to just brainstorm with you guys and talk about strategies for managing your managed care contracts. You know, one thing that I would always say to you is really when you sit down and start thinking about, like, do I want to renegotiate these contracts? Do I need to renegotiate these contracts? You're really going to want to assess, analyze, and then, you know, have a strategy and a plan to negotiate. You're going to really want to dig into, you know, what is your cost by location? What is your cost and by discipline? Do you have a higher acuity population? You know, what kind of patients are you serving? And those are really important things for you to think about and apply. When you're looking at, you know, your profitability, you know, you've got to set, like, what do I want my margins to be? You know, are we profitable today? Are we losing money? You know, what are the things that, you know, where are we going? Where do we want to be? You know, so then once you get all that laid out, it's much easier then to look at your contracts, look at your higher volume contracts, and have a strategy around how do we open this up for negotiations? Where do we want to start? You know, and then be thinking about your value. What do you bring? What is your worth? You know, when you're talking to these payers. So one of the things that I think is key is forming a partnership, you know, knowing who your network rep is, knowing who your contracting specialist is, and having key relationships with them. Some of the things that are important to them, it may seem very basic, but have an ease of doing business. And what I mean by that is, are we doing things as providers? Like, are we keeping our demographic information updated? Are we keeping our pay to, like, our lockbox and our information current? Those are really important things and things for you to stay on top of. Very hard, not easy to do, but definitely key areas where we need to really make sure that we are easy to work with when it comes to that. Oftentimes what happens is, if you've not kept that up to date, right, and you do want to open a negotiation, that's the first thing that they're going to say is, well, we've got to clean up all your records, you know, and that can be a delay depending on how far behind they are in their system management on updating, you know, provider information, or if they've got a big project going on, things like that. So that is really, really key. And I will tell you that one of the things that I've recently seen is that there's been language in contracts around reducing your rates for not keeping up your demographic information. I even negotiated that out because I'm like, yeah, no, we're not going to do that. So understand that it is important. And I know you know this, but it's not easy. I also know it's not easy, but that is something that's very key for them and a part of that ease of doing business. The other thing is, a lot of times when you may send them a formal notification to open up your contract for negotiation, one of the things they're going to look at and talk about is, you know, do they play in all of our products? You know, sometimes it may not be something that you can do, but it is kind of important to payers that you're not just in the commercial product, right? Or that you're willing to participate in new products that they're entering into, or, you know, new networks that they're trying to build. They're looking for people who are willing to go with them on their journey, right? So if you can participate in their commercial products along with their Medicare Advantage and their exchange and their Medicaid, that's also a value add for them. Is that somebody's, you know, all the way in all their products, you know, contracted across the board, very important for them. Sometimes payers require you be in all products, right? You don't have a choice to pick and choose, but in those payers that allow you to choose what products you want to participate in, that's just something to keep in your mind and kind of a good strategy. The other thing is when I talk to you about knowing your value, you know, knowing your worth, kind of knowing the pulse of what is important to the payer. You know, they're looking to, you know, where can we reduce costs? A lot of inpatient readmission is high cost for them. ER visits are very, you know, costly for them. And of course, no one wants their patients going to the ER all the time. So as you're in the home, you know, and thinking about and assessing these patients, these are important things to share with the payer when you bring your value to them. You know, you can identify things in the home, social determinants of health I have up here, because it's really the thing that they're beginning to really, you know, as you saw in Brian's slide earlier, it's really things that they're beginning to hone in. You know, do they need meal prep help? Do they need, you know, are they having trouble bathing? Are they, you know, needing help with medication reconciliation? Are they at risk for falls? All of these things are things that you can begin to have discussions with payers on, things that you and your organization can identify and help them with, right? So if a patient then, you know, is identified as at a fall risk and you can help them with that, that could prevent like an inpatient, you know, admission. It could also, you know, reduce an ER visit. So these are all things that bring value that you can begin to talk to them about and form programs around. And as you do that, one of the things that's so key is that you become a resource for them as well, because there's oftentimes I'll get a call, and they'll ask me different things like, hey, we're looking at adding this benefit to this, product. What does that mean for you? What are your thoughts around that? Or, hey, we have this type of patient. We're not sure where to place this patient. Can you help us? If you can't place it, do you know someone that could take the patient? So you then, once these partnerships are formed and these relationships are built, they then rely on you and are comfortable with you to come to you as a resource, which was really, really important and a value add, because then the road goes both ways, right? Which is so, so important. So when you think about contract negotiation, some of the things that I would suggest you do is never have an evergreen contract if you can keep from it. You don't want that just goes on and on forever. You really want to try to limit your contract to a 2-year term, especially if you've got rates in there, right? So you want to be where you can go in, get that contract current, number one, and then have that 2-year deal where you can always be looking at your reimbursement, always have the opportunity to open up that contract, right? Because as Sam was talking about, it's not always just about rates. Rates are probably the number one thing that are important, but timely filing limits, you're going to want to have good language around your timely filing. You want to really try to negotiate that. If you can negotiate authorizations or options around authorizations, that's always nice to ask. A little bit harder to do, but still something that you should be having conversations and the challenges that are posed, right? So those are really, really key things. The other thing is if you have a specialty program, right? Like if you have a cardiac program that you've been very successful in implementing with your payers or your patients, it's really important to bring that to the payer. They would be very interested in, you showing your value, demonstrating, how you've improved patient care, how they've improved quality of life, how you've reduced cost. Those are all key things that are really important in your contract negotiation as you have this partnership and say, hey, we want to work with you. What are things that we can do? One of the things as you look at looking at your contracts and beginning to open up your contract for negotiation, I would encourage you to take a snapshot of all your contracts, and their rates, and then put your volumes around that and say, okay, where's my highest volume? Where's my highest rate? Where do I want to be? So those are key things that you're going to want to do to optimize your rates and open up that negotiation. Sometimes though, sometimes you are going to run into challenges where they say, oh, well, we have standard pricing. We don't do special pricing. And so that's really when you're going to want to go in and talk about, can we do a value-based arrangement, or can we go into a pay for performance where we help you with some metrics, closing out metrics and a pay for performance scenario, then moving into maybe a value-based or a risk, assessment to get additional revenue coming into your organization. I mean, it's always nice when you can do both, right? Get the rates that you need and do like maybe a risk-based or a value-based program. But if you run into a scenario where, they're just not moving on the rates, there's always room to talk about where you could help them, right? And help them with the rate negotiations. Reducing cost and benefit from your rate negotiation. So real quickly, we did want to talk on contract management. I think in my experience that contract management is an everyday challenge that I work with, just one of the things that we suggest is, like Sam mentioned earlier, is the payer matrix. Payer matrix is a really good tool that you could create and have key contract terms. You could have your filing deadlines in there. You could have any, specific nuances that your organization struggles with. Maybe it's, an authorization deadline or how long it takes to get an authorization. You could put key terms in there. You could even put your rates in there. I would caution you, if you're going to do that, to probably limit it to only certain people in the company. It is a good tool to have with rates, but obviously you would never want that to leak outside of your organization, because it would definitely be a breach of your contract. But these are some of the things that we've implemented, and it's been really beneficial for our teams with the information they've been able to see and the information they've shared with us that they need, right? You can even tweak it where your legal teams can see different terms. Term clauses are always important, arbitration clauses, dispute resolution. If you're having to really have to really think about, okay, we've got XYZ, out on the books, and we're really going to have to enter into this. Those are key terms that you could have in there that you could go to quickly. The other thing that I talked to you really quickly about is a contract repository where you house all your contracts, have a naming system. Much easier to find your contracts when you have them in a repository rather than, our desk drawer and things like that. So really good to have a contract repository and a consistent naming, convention where you can get those copies, those fully executed copies into your contract repository. Again, I think some of the challenges we all have with the management of agreements is having a fully executed agreement. That's one of the things I chase all of the time in the managed care department is, did we get the fully executed agreement? Do we have it loaded? Are we ready to go? And really making sure that you have that. So very challenging, not an easy thing to work with the payer on either. They're really not good at getting them back to you either. So that's the challenge that you're always chasing. I would also say that, your aged agreements. One of the things that I would suggest when you're looking at negotiation is your aged agreements. These are things that you're really going to have to think about, like at some point when you look at that payer mix, your payer mix balance and your referral source balance, from your referral sources and the payer mix that's coming in. If you find that you've got a really old contract, you're really going to have to think about the business decision you want to make around that. Is that a renegotiation or is that a termination, right? What balance do you want? Do you just want your big players like your United, Aetna, Humana, right? Or your Blue? And then, maybe the smaller player in the market, do you term that? So those are things that you've got to look at and look at your mix when you're looking at all that. And so I think it's just important. I mean, it's not easy for anyone to think that, I'm going to term a contract, but remember you can, that's why there's term language in those contracts. Sometimes, it's not beneficial for you anymore or your organization. So clean it up and, move on, and that's not always, I think, something that we think about. But the other thing is the management of agreements. One thing that I think that also can be a challenge is in credentialing, knowing that you're through that process. Now it's time to contract and look at the rates and negotiate. Sometimes that goes hand in hand, the credentialing and the contract negotiation. Sometimes it's separate. So always just having a pulse on the credentialing is very, very important because it's so much tied to contracting. One of the things that you may consider in your payer matrix is putting it due when you're due for recred, right? Because we come up for recred every 3 years, and we really should be better at tracking that. And did we update our demographics so that the packet goes to the right place and that I've received it and that I'm compliant and I don't get termed in one of my bigger payers? So those are all things that come together in the big scheme of the contract management that are so important. So the next thing I touch on really quick is the education. Payers, once you form that relationship, there are various things that you can educate the payers on. You can talk to them about, what keeps you up at night? What are your pain points? Let me show you my worth and my value to come in here for you to help you, right? Like, where could we look at your high acuity population that's non-compliant? And then could we do some kind of joint venture where we share in the savings of reducing costs and getting those patients compliant? The other thing is continuing to talk about their non-skilled home care. That's an area that the social determinants of health that they're beginning to expand in, and if they're not a big Medicaid player, this is going to be new to them. They may be a little bit clunky. While they're interested in it, they're not as experienced as they're used to paying for, labs and MRI and PCP visits, right? So these are things that they're moving into a new space. So really helping them identify where your agency can really help them and bring value there and have that holistic approach with that patient, right? It's that full 360 care, bringing that value, reducing that cost, and helping, the patient be successful and in their way of life, and then also the payer reduction and reducing cost. The other thing is, as I've talked with payers, I'm really trying to push them on hospice and talk to them about hospice. They're so used to reverting back to traditional Medicare, right? So I'm always like, I'm here for you if you want to talk about hospice. What can we look at around hospice? We have a lot of good ideas around hospice. We know it's a sensitive issue, and that's why we want to be so sensitive and plugged in with the payer as well. Not just our physicians and our referral sources and the patient and the caregivers, but also with our payers, so they have a full understanding of the care and what what support can be provided for those caregivers when patients are in hospice, and just really preparing our story and talking about that. Talking about early transition is good. A lot of times early identification and all of these programs is really, really beneficial. And then really quick on telehealth, I know we've kind of begun to expand in that space. I think it's always important to talk to your payers about things that you're seeing. Are you running into barriers, early adoption, or are patients just slower to take on that? And then on some of the payers that you are allowed to bill for, are you getting paid, right? And are you getting paid timely? And is it where you need to be? So I think that we have a lot of great opportunity in that telehealth space as it, due to COVID, and then beginning to expand to really be a source of education on what we're seeing, maybe the barriers and what may make it more successful. So all of these are great, strategies around, all of these are great things that I think that the payer has really talked to me in depth about a lot, and just very interested. So just continuing to talk to them, building the relationships, opening up those contracts, for negotiation, and keeping them in a very, tight window so that you can continue to have consistent reimbursement increases, because it's much easier to get a decent, a smaller increase that gets you where you need to be to meet your cost, your targets, and your margins, that you've set, rather than trying to have to go from, $80 to, trying to go to 105 or 110 or 115, right? Because we know that that's going to be a challenge. So really exciting space to be in, and working with the payers, and I'm hoping that you found this helpful and gave you some good feedback on what you can do to be successful with the payers.
Thank you so much, Beth Ann. That was awesome. We so appreciate all of your insight from your work with the provider and from the payer side. It's interesting to get a glimpse into what the payers are thinking about so that we can effectively work with them. We wanted to round out here just with some key takeaways from the presentation before Brian jumps into some questions from the attendees, some of the Q&A. Hopefully, if you haven't submitted a question yet, you can do so right now, and maybe we can get around to it. Some of the key takeaways that we really want you to learn from today is that Medicare Advantage is growing, right? The expansion of benefits such as hospice and non-skilled home care. It is something that's, if you're not dealing with it a lot yet, it's probably coming down the pipeline for you. As the CBO says, they estimate 50% of all beneficiaries by 2030 are going to be in an MA plan. So we have to be thinking ahead about how to manage these contracts and the challenges. We talked through some of the operational revenue cycle challenges that MA places on us in managing those plans. So it's important to understand, take an internal look at how you guys, how providers are dealing with those challenges today, and can you more efficiently manage some of those processes so that you don't have to just hire an entire army to deal with all the challenges that MA presents us. And I thought that Beth Ann provided some really good feedback and recommendations on knowing your worth. Take a look at you as a provider. What area are you in? What specialty programs do you have? What are some of your quality scores? And what can you offer to the payer? Because that's going to be really key in some of your negotiations and your conversations with them, and really solidifying some of those partnerships, having a really good idea of what value you provide. And be informed about your business. Before you go to that negotiation table, take a look at your costs. Can you decrease those? Is that your optimal cost? Is that your target cost? What are some of the desired margins that you want to achieve? What's your ultimate desired margin? What is acceptable for you? And have that in mind when you go to the table with some of those payers, so that you can be informed and have some smart conversations. And lastly, us as providers who work in home health and home care and hospice and telehealth day in and day out, it's really our responsibility to provide those payers educations, all the way from on the phone with provider representatives on collections calls, all the way up to sitting at the table with those payers, renegotiating your contracts. It's really going to be up to us to provide education on the value and benefit of some of these programs. Brian, you want to take us away with some questions?
Absolutely. Sorry, I was struggling with the unmute button there for a second. So we do have a few minutes left here and wanted to get to questions. Like Sam mentioned, if you have anything that you haven't submitted yet, please feel free to put it in the chat or the Q&A. Going to send this first question to Beth Ann, and I apologize. It's kind of a multi-part that kind of combines the amalgamation of comments that we've been getting. So they're all on a very similar theme about the concerns of rates and a lot of times payers having, this is our rate, take it or leave it. And I know you mentioned some things about, if that's the case, asking for the value-based or the pay for performance, trying some more creative angles. But how do you draw the line at whether a contract is worth taking? And are there certain scenarios, do you think that it's beneficial to build the relationship looking long-term, even if the rates aren't immediately profitable?
I would say that I would say a couple of things. I think that one of the things that I've experienced is a lot of times what I've seen is that we are sent letter of agreements, right? And you're going out to sign a letter of agreement so they can see if they can build these networks, right? And so, or when they're adding a new benefit, to build these networks, it's so important at that time to begin that conversation around the rates at that time. And a lot of times what I've done is on letter of agreements, I don't sign them, right? I don't join the network immediately because I know what portion of the market I have. And I know if there's a big need for me, that they're going to have to eventually come back to me, right? So that's one strategy that we've got there. And then a lot of times you're right, they say take it or leave it on the rate. So I think what you've got to do is really look at your balance, right, of your payer mix and decide, where do you have rates that are acceptable, right? And do you have the volumes that you need there? And then I think you also have to have honest conversation with your referral sources, around, we're really going to have to consider maybe not taking XYZ payer because their rates are so low. And we can't negotiate, they won't negotiate with us. And so we're going to have to make some business decisions around that. So definitely some hard decisions sometimes to make. You do sometimes have to take them depending on the balance that you've got and the other business that it potentially could bring you. So I think it's just kind of what your market warrants too. The other thing is being informed on the market. How many MA lives do they have? Do they have the bulk of the market, or are they a small player and you're just having to get that, the majority of their patients. So I think it's really assessing that balancing act, talking to the payer, saying, we're really going to have to make some business decisions if you can't work with us, or we can't go into some kind of performance program with you to get additional reimbursement, because, if you're losing money and it's, not beneficial, you may have to really consider terming that agreement. So, which is a hard thing to do. I get it, but just continually having conversations with them, keeping them informed. The other thing that we've also said is, we've gone to our hospital systems and told them, hey, we're really struggling. We can't seem to get the payer to negotiate and on really, really extreme rates, right? And so we've even used them, to say, well, next time you guys negotiate, this might be something you bring up, that we don't have a place to refer your patients, right? Because nobody's wanting to stay in your networks or contract in your networks. So.
Thank you. That's excellent feedback and a few suggestions there. I mean, I think looking at that as well, to your point, it's not always an easy conversation to have, but here's several different avenues that we can take a look at to try to remain successful. I know we're right up on the hour here, but I think we got time for one or two more questions. This one here actually just came in. Have you found, how do you find contacts? How do you find the right people to talk to make sure that you can have these conversations? You can bring up some of these topics when you're either negotiating for the first time or renegotiating.
Well, typically what I do is if I don't have like a payer relations contact, they usually have a payer on their website. They'll have a provider section and it'll say, locate your rep or contact provider services to find your rep. And I usually go in through that general email box and tell them, hey, I'm looking for my network rep. Here's my branch and where we're located and here's who we are. Please have them reach out to me. I need to discuss my contract. So that's typically how I get in there. If they haven't responded quickly, I'll a lot of times call provider services, their 800 number, and route a call that way to them as well. So usually, though, the main email box will get me there. And a lot of times on their websites, they do have the network reps by area. You kind of have to dig for it, I'm not going to lie, but they do have a little map, and you can click on your area and it'll take you to your provider rep. And that's usually how I find them if I don't know who they are. But those are ways that I typically locate them and continue to follow up till they come back to me.
That's great feedback. And then I'll just add one thing in from the operations and rev cycle side of that is make it a collaborative effort across your organization. So it shouldn't be, I mean, Beth Ann, you're responsible for really driving these contracts, but work with your billing team, work with your authorization team. I mean, Sam mentioned you have that payer matrix, include some representatives there. Try to talk to anyone you can until you can find that right person, and then make sure that's shared across your organization. So. All right, so I know we're just past the hour here. If you do have any additional questions, we do have our contact information up on the screen. Again, we'll be sending out a one-page summary of everything here, as well as a video replay recording. And if you want to get the handouts before leaving here, they're in that handout section there for this slide deck. So thank you, Beth Ann, very much. We loved having your expertise on with us. Thank you, Sam, for presenting here as well. And thank you, everyone, for joining. We hope you have a good rest of the day.
Thank you.
Thank you.
Thanks, Beth Ann. Have a good rest of the day.
You too.